Hello doctors. Today we are here with another topic of pediatric surgery, that is anorectal malformation. So before going to the anorectal malformation proper, first we will know the anatomy of the rectum and the anal canal in short. So here you can see a picture. This is the levator ani muscle. This is the levator ani muscle in the both the side. In V shaped you can see the levator ani muscle. Then this is the external sphincter muscle. The external sphincter muscle have three parts. This is the deep one, deep, superficial and subcutaneous. Three parts of the external sphincter muscle. And then we have the internal sphincter muscle. This is the internal sphincter muscle and this is the external sphincter muscle. And this is the pectinate line. Above the pectinate line, we have the endodermal origin. Below the pectinate line, we have the ectodermal origin. Okay. Now, this is the another picture to understand the anatomy better. This is the pubic bone and this is the rectum and then the anal canal. And this muscle, in a sling like, this muscle is puborectalis muscle. Okay. Puborectalis muscle, as you can see, helps in maintaining anorectal angle. So this is puborectalis muscle. Fine. Now, as I have told, what are the muscles of the anorectum? Number one is internal anal sphincter, that is present in the upper 3/4 area of the anal canal. Second, we have the external sphincter. As I have said, we have three parts of the external sphincter, that is deep, superficial and subcutaneous. Then we have the levator ani muscle, puborectalis muscle and a striated muscle complex. The striated muscle complex is made up of puborectalis muscle and the deep part of the external anal canal. So this is the levator ani muscle. This is the deep part of the external sphincter muscle. This deep part of the external sphincter muscle and the puborectalis muscle forms the striated muscle complex. Now, what are the sensory elements? The sensory elements are rectal wall nerve ending and stretch receptors, puborectalis muscle, striated muscle complex and anal mucosa. The motor elements are rectal wall, levator ani, puborectalis, striated muscle complex, internal sphincter and external sphincter. These are the motor complex. And nerves that are present in the around the anorectal canal. Parasympathetic is originating from the sacral 3rd and 4th and sympathetic is originating from the lumbar 2nd, 3rd and 4th. Somatic is from the anterior root of sacral 2nd, 3rd, 4th via the pudendal nerve, then via the sacral branches of the 4th sacral nerve. And we have the also sensory supply for touch, pain, fine touch, all these receptors are also present. So here we can see the complex and multiple plexes around the anorectum. This is the sympathetic trunk which is from the lumbar, as you can see, sympathetic from the lumbar 2nd, 3rd and 4th. And sacral plexes are there for the parasympathetic supply, which is also known as pelvic splanchnic nerves. And we have the pudendal nerve for somatic. Now, anorectal malformation. The incidence of anorectal malformation is 1 in 5,000 live births. Male equal to female ratio are almost equal. African and black people have more chances of having anorectal malformation. 13,223 babies with anorectal malformation are born in India every year, every single year. And there are many theories which tries to explain about the anorectal malformation, why it occurs. The first conventional theory was that the urorectal septum, I will teach you next what is urorectal septum. Urorectal septum migration abnormality causes anorectal malformation, but all the multiple anorectal malformation are not only explained by this theory. So another theory in 1978 was given by Chatterjee and Roy in various malformation of hindgut. In the development of hindgut, there are various malformation which causes anorectal malformation. And in 1986, Vander Pate have postulated in theory that due to problem in the reabsorption of the cloacal membrane. What is cloacal membrane? I will tell you as this video goes on. Due to reabsorption problem in cloacal membrane, there is Van der Peet theory is that because of that there is anorectal malformation. So we have to know the embryology of anorectal malformation, and this is very important. So as you can see in this picture, this is our primitive embryo. Here you can see there is anterior intestinal portal and this is the posterior intestinal portal. What are these portal? As you can see, this is in yellow color. This portal, anterior intestinal portal, is the junction between, this is the foregut and midgut. The junction between the foregut and midgut is the anterior intestinal portal. Then we have the posterior intestinal portal. Posterior intestinal portal is the junction between the midgut and the hindgut. This is the midgut and this is the hindgut. This is for the posterior intestinal portal. Fine. Now, this is the aorta, okay, and the artery for foregut is celiac artery. For midgut is the superior mesenteric artery, and for the hindgut is the inferior mesenteric artery. Okay, you have understood this. Now, second part. You can see another thing here. As I have said, this is foregut, midgut and hindgut. Okay, so this part, this extension of a part of hindgut towards the umbilicus, this is the umbilicus, towards the umbilicus, this part is known as allantois. I have told you about allantois in my video of umbilical abnormalities in children. So this is the allantois. Now, if we draw a line, here you can see via the blue dotted line, I have drawn a line. If you draw a line from the allantois to the hindgut, then we can divide the hindgut into two parts, that is pre-allantois and post-allantois. Now we will see what are the structures that derives from the pre-allantois and post-allantois. From pre-allantois, we get left 1/3 of the transverse colon, descending colon, sigmoid colon, and part of the rectum till the middle rectal valve. As you know, there are 3 Houston valves in the rectum, so up to the middle rectal valve that we get from the pre-allantois. So I will tell you one more thing. Like what I have said, posterior intestinal portal is the junction between the midgut and hindgut. So where up to is the midgut? Midgut is up to, this is medial 2/3 of the transverse colon. Up to this is midgut, and the lateral 1/3, descending colon, sigmoid colon, rectum, anal canal, these are all hindgut. So as you can know, from the pre-allantois, the left 1/3 of transverse colon, the descending colon, the sigmoid colon, and the part of the rectum till middle rectal valve is from the pre-allantois. And what are the structures that develop from the post-allantois? As you know, it's very easy, like rest of the rectum will be developed from post-allantois. Apart from that, upper part of the anal canal is formed from the post-allantois. And most of the mucous lining of the urinary bladder and urethra is also developed from the post-allantois. So I will repeat this for you again. So we have the midgut and hindgut. Then if we draw a perpendicular line from the allantois, we can divide the hindgut into pre-allantois and post-allantois. These are the structures from the pre-allantois, and these are the structure from the post-allantois. Fine, clear? Now, from post-allantois, a part of the hindgut dilates. This is the hindgut, okay? This is the hindgut and this is the allantois in a much simplified picture. Now, the post-allantois part, this is the pre-allantois part, this is the post-allantois part. The post-allantois part dilates and it forms endodermal cloaca. So, this part is known as endodermal cloaca. Fine? And this part which is below here also you can see this part which is below, this is the ectodermal cloaca. Fine? We have 2 cloaca, that is one endodermal cloaca and ectodermal cloaca. So where this endodermal and ectodermal cloaca meets, as you can see, this is a bilaminar cloacal membrane. So what is cloacal membrane? Cloacal membrane is formed from the lower lining of the endodermal cloaca and ectodermal cloaca. The two bilaminar lining forms the cloacal membrane, and this is the allantois. Fine. Now, as you can see, there is a dip in between the allantois and hindgut. This is the where there is starting of formation of urogenital septum. In the next picture, as you can see, the urogenital septum depends. So it is deeper now, and it is much more deeper now, and it separates into two. This is the normal anatomy. But as you can see, when it depends, it forms this side, it forms the primitive rectum, and this side it forms the primitive urogenital sinus, from where the urinary bladder and urethra will develop, and from this there will be development of the hindgut and our anorectal canal. Fine. If there is any connection in between the primitive rectum and the primitive urogenital sinus, this is known as cloacal duct. Sometimes this is asked in MCQ, what is cloacal duct? So now you know this is cloacal duct. That is the communication between the primitive rectum and the primitive urogenital sinus forms the cloacal duct. Okay. I will repeat once again for you very quickly. So we have the posterior intestinal portal, that is the junction between the midgut and the hindgut. This is the junction. From this part, this is the midgut, and left 1/3 from this part is the hindgut. Now, we have the allantois. When we draw a perpendicular line, we form a pre-allantois and post-allantois. And this post-allantois dilates and form the endodermal cloaca. And we have the ectodermal cloaca below. And the membrane in between these two are the bilaminar cloacal membrane. And this is the urogenital sinus. As the gestational age goes on, the urogenital sinus deepens and it forms two pouches. One is the primitive rectum, another one is primitive urogenital sinus. But if there are communication in between the primitive rectum and the primitive urogenital sinus, this is known as cloacal duct. Fine. Now, we have three things here. One is the primitive rectum. Another one is the cloaca, ectodermal cloaca. I have told you this. This is the ectodermal cloaca. This is the endodermal cloaca. So the ectodermal cloaca, there is a pit present here also and this side also. This side we have a pit. This is known as primitive urethral groove, from where the urethra will open up. And we have another pit here that is known as proctoderm or anal pit. Fine. So we have primitive rectum. In between the primitive rectum and the proctoderm, we have the anal membrane. This bluish, lightish blue color, you will see this light blue color in between them. Yellow color is primitive rectum. The black line is the anal pit, and the blue color is the anal membrane. Fine. Now, how does the development begins? This proctoderm deepens. It becomes more deep, and then later on, the proctoderm meets the endodermal cloaca, and where the anal membrane lies, it forms the pectinate line. This is the pectinate line. This is the pectinate line. Above the pectinate line, we have the endodermal origin, and below the pectinate line, we have the ectodermal origin. Now you can know easily. So this is the development of the anorectal canal, embryology of that. It's very important to know because as you know this, it will be very easy for you to know the anorectal malformation as we go on with the topic. Fine. Now, we will know the genetics behind the anorectal malformation. The anorectal malformation may be associated with syndrome or non-syndrome. If it is non-syndromic ARM, then only presentation will be anorectal malformation. There will be no other abnormality. It may be autosomal dominant or recessive or familial, and it is more common in males. Syndromic ARM is more complex phenotype, as many complex and many other symptoms are also present. It might be chromosomal, genetic, teratogenic, or others. An associated malformation with ARM is 50 to 60%. High abnormality has more malformation, and high type of ARM have 13 times more prone to malformations. Now we will see one by one the respective systems and what malformation are present. Like in cardiovascular, first, 1/3 of the patient with anorectal malformation have cardiovascular defect. Most common is ASD, second most common is PDA, then tetralogy of Fallot and ventricular septal defect. Most common in cardiovascular is atrial septal defect in ARM. Now, gastrointestinal anomalies. Tracheoesophageal fistula in 10% of cases is associated with ARM. Most common cause of mortality in ARM is because of the tracheoesophageal fistula associated with it. Apart from that, there may be duodenal atresia in 1 to 2% and Hirschsprung disease in 3.4%. You have to know one thing, that is Currarino syndrome, very important. Currarino triad have three things. Number one is hemisacrum, number second presacral mass, and then imperforate anus. Mostly low-lying anorectal malformation is present. So three things: hemisacrum, presacral mass, and imperforate anus. Now genitourinary abnormality. 1/3 to half of the cases have genitourinary abnormality. As you know, in the development also, from hindgut only, from pre and post allantois, from post allantois urinary bladder also forms, and a part of the rectum and anal canal also forms. So genitourinary abnormality is very common. That is, therefore 1/3 or half of the patient is associated with genitourinary abnormality. Most common genitourinary abnormality is vesicoureteric reflux, that is present in 30 to 40% of patients, or it might be associated with renal agenesis or dysplasia. The most common genitourinary abnormality is VUR. Apart from that, there may be undescended testis in 20% of cases, or hypospadiasis may be present in 6.5% of cases. Now, gynecological problem, hydrocolpus may be present, or uterine malformation, bifid uterus, bicondyloid uterus. These uterus might also be present if the child is female. Now, chromosomal anomalies. Chromosomal anomalies, trisomy 21, 18, 13, 22, sex chromosome aneuploidy. These are the chromosomal abnormality, very common. Anorectal malformation in Down syndrome are generally not associated with fistula. It is said that if there is high ARM, then there is more chances of associated with fistula. But if there is Down syndrome, anorectal malformation, even if it is high, generally it is not associated with fistula. So it is important to remember. Now, classification. Classification, we have the Stephen's classification. We have multiple classification. We will see one by one. First is the Stephen's classification in 1963. It is based on PC line. PC line is pubococcygeal line. So pubococcygeal line, according to pubococcygeal line, if you draw a line between the pubis symphysis and the coccyx, if the ARM is below it, then it is low ARM, and if the anorectal malformation is above that line, then it is high ARM. So this is the pubococcygeal line according to that Stephen's classification. Then we have the Santiuli classification, that is on the basis of levator ani muscle. I have shown you the levator ani muscle in the starting of this video. So either it may be supralevator or infralevator, that is Santiuli classification. We have two classification. Another classification is international classification. You have to just remember the name. This is too complex and there are 40 subtypes of the international classification of ARM. Another is widespread classification, which is, you should remember, widespread classification is boys and girls. It is different. It may be high. In high cases, boys and girls have similar classification. In high case means there is anorectal agenesis with rectovesical fistula or without fistula. In boys, there is rectovesical fistula. In girls, there is rectovaginal fistula. Because in girls, we have the urinary bladder, then we have the vagina, then we have the anorectum. So rectum and vaginal fistula is more common in females, as the no vagina is present in boys. So anal canal and the urinary bladder, rectum and the urinary bladder fistula is more common in boys. So therefore in boys, rectovesical fistula, and in girls it is rectovaginal fistula might be present with anorectal agenesis, or there might be rectal atresia, that is high type. In intermediate type, in boys, there will be rectobulbar urethral fistula, anal agenesis without fistula. In low, there will be anocutaneous fistula and anal stenosis. In intermediate, in girls, there will be rectovestibular fistula, rectovaginal fistula, anal agenesis without fistula, or anovestibular fistula, anocutaneous fistula, or anal stenosis will be present. So this is widespread classification. Now we have Pinna's classification. Pinna's classification is based on requirement for colostomy, whether the colostomy is required or not. Like in male, if there is cutaneous fistula, rest of the anal canal is normal, but there is only cutaneous fistula or stenosis, or there is an anal membrane present only, then no colostomy is required. We can correct that directly. But if there is rectourethral, bulbar fistula or prostatic fistula or rectovesicular fistula, then there is a need for colostomy. This is Pinna's classification in male. So colostomy is not required in these cases and colostomy is required in these cases. In female, cutaneous fistula, we do not need any kind of colostomy. But if there is vestibular fistula, vaginal fistula, persistent cloaca, imperforate anus, or rectal atresia or stenosis, then the patient needs colostomy in first stage. Might be in later next stage we will correct the anomaly. Now, we have seen already 5 classification. One is Stephen's classification according to pubococcygeal line, high ARM or low ARM. Santulli classification, either it is above the supralevator or below the levator muscle, the supra or infralevator. International classification, just remember the name. Widespread classification is divided into high, intermediate and low and different in boys and girls. Then we have Pinna's classification according to requirement for colostomy in boys and girls. Now we have the Krickenberg classification, that is based on some are the major clinical group and there is a minor clinical group, that is given in May 2005. In this classification, major clinical groups are perineal fistula, rectourethral fistula, bulbar, prostatic fistula, rectovesical fistula, vestibular fistula, or there might be no fistula or anal stenosis. And rare and regional variants are pouch colon, rectal atresia, stenosis, rectovaginal fistula, H type of fistula and others. These are the minor. So what here you can see a term that is pouch colon. So what is pouch colon? Pouch colon is rare anorectal malformation where all the parts of the colon is replaced by a pouch like dilatation that connects to the urogenital tract via a fistula. So the colon is not normal. The colon is dilated congenitally in the neonate. So this is known as pouch colon. Colon is like a pouch. Therefore, this is known as pouch colon. Now, pouch colon can be divided into 4 types on the basis of length. We have 4 types, as you can see, 1, 2, 3 and 4. First, there is normal colon is absent. There is no normal colon. As you can see, this is the ileum, this is the appendix, and then we have fully dilated colon, and dilated colon is opening into the rectum. So this is the pouch colon. Normal colon is absent and ileum opens into colonic pouch. Number 2, we have only the cecum is normal. Rest of the colon is pouch and the ileum is opening into the cecum, which is normal. Only the cecum is normal, rest of the colon is abnormal. In type 3, presence of a significant length of normal colon between the ileum and the colonic pouch. Means some part of the colon is dilated and some part of the colon is normal. So this is the normal colon and this is the dilated part of the colon. In type 4, presence of near normal colon with only terminal part of the colon converted into a pouch. This is the terminal part of the colon which is only converted into the pouch. Rest of the colon is normal. So one has the worst prognosis, most severe cases, type 1 type of colon, pouch colon, congenital pouch colon. Another type of classification that can be given, that is based on the need for coloplasty. In type A, partial short colon length, normal colon and proximal to more than 8 centimeter. Like the size, the length of the colon which is normal is more than 8 centimeter. Fine, so there may be good prognosis. But in type B, there is complete short colon, absent normal colon, or length of the colon proximal to the pouch is less than 8 centimeter. So the length of the normal colon is less than 8 centimeters. So it has little bit poorer prognosis. It has a better prognosis if the normal colon is more than 8 centimeter. So these are the two classification of congenital pouch colon. So we have covered a lot about ARM. This is the part 1 of ARM. I will make a video on part 2 as ARM is a big topic but important topic. It is asked in both UG and PG exam, postgraduate level also. You generally get a long question on ARM every year. And anorectal development is very important, which I have explained you in brief. So thank you for watching, guys. Please do like, share and subscribe to my channel so that I can make more free videos for all the medical students out there. Thank you, guys.